My name is Chantel Gray, and this is my video OSCE for the respiratory assessment for Nursing 518. So to start, I want to gather my equipment. So for this exam, I'm going to need a stethoscope, a ruler, and a pen. So then I'm going to wash my hands and don my appropriate personal protective equipment. Once I enter my patient's room, I'm going to introduce myself and explain my purpose. So I'm going to say, hi, my name is Chantel Gray. I'm a nurse practitioner student. I'm going to be doing a respiratory exam on you today. Is that all right?
Yes.
Perfect. So then I'm going to provide the patient with privacy. I'm going to position him and have him remove his shirt, which he's already done quite nicely. So I want to be able to see the full anterior and posterior chest. And I have the patient sitting for this exam, which is appropriate because he's well and able to do so. So then I'm going to take a look at his general appearance and grab a set of vital signs. So while I'm doing his general appearance, I can also be doing my inspection. So I'm looking for his posture. Is he slumped forward, tripoding, really struggling to breathe? I'm looking at the rate, rhythm, depth, and effort of his breathing. So does he have a regular rhythm? Is he really working? Looking for those accessory muscle use. So I'm looking for scalene muscle retractions. I'm looking for sternocleidomastoid muscles contracted. I'm looking for suprasternal indrawing, supraclavicular indrawing, as well as intercostal indrawing anteriorly and posteriorly, which would tell me that the patient has an increased ventilatory demand or respiratory muscle fatigue or both. So I'm looking again, looking at the symmetry of his chest movement, looking for bruising, obvious deformities, looking for any scarring or abnormal coloring or anything that looks suspicious anteriorly or posteriorly, looking for lesions or masses. I'm also looking at his mouth, so looking for any signs of drooling, looking for circumoral cyanosis or bluish discoloration of the lips. So I'm also looking for cyanosis in the nail beds or signs of clubbing, which would be an indicator of chronic lung disease like COPD. So I'm looking both hands, and I don't see any evidence of cyanosis or clubbing, so that's perfect. I'm also looking for like congenital deformities like a pectus excavatum or a pectus carinatum, or any other abnormalities that way. I'm also listening for any abnormal breathing sounds that are fairly obvious, like stridor or wheezing, that are going to represent a significant level of distress. I'm also looking at the lateral diameter of the chest, comparing it to the anterior-posterior diameter of the chest. So the lateral diameter should be greater than the anterior-posterior diameter of the chest. If the AP diameter starts to kind of creep up and become similar to the lateral diameter, that's what we call a barrel chest, and it would be indicative of a chronic lung disease, like a hyperinflative condition, like asthma, like poorly controlled asthma or COPD. So once now I've seen that he's got nice, easy work of breathing, he's no obvious signs of trauma or injury to his chest wall, he's quite comfortable. I feel comfortable moving on to palpation. So I'm going to palpate over the anterior and posterior chest. So I'm looking firstly for subcutaneous emphysema or crepitus, which is like an abnormal grinding sensation, looking for deformities or any areas of tenderness. So I'm going to start, just let me know if any of this feels tender, okay? None of that feels tender?
Nope.
All right, so then I'm going to do the same thing posteriorly. So I'll just have you spin around. Okay, same thing for the apices, all the way down between the scapula. Perfect. Okay, so I'm satisfied with that. I didn't find anything abnormal, so I'm going to move on to my next test, which is the chest expansion. So I'm going to find the lower level of his lung field, which is about T10, and I'm going to push my hands in slightly. I'm going to have the patient take a deep breath in and out. Perfect. So I'm looking for my hands moving apart symmetrically, and I'm looking for them to move apart at least 2 centimeters. So the symmetry is important because if you have a unilateral chest wall leg, that can indicate like a pleural effusion or like a massive bronchiectasis or like a lung collapse on one side. If you have like a bilateral restricted movement, that would indicate a restrictive lung disease or something else going on. So I'm satisfied with that lung expansion posteriorly, so I'm going to have my patient spin around and I will do it anteriorly. So again, I'm going to find the lower level of the sternum and the lower ribs, and I'm going to push my hands in. And same thing, take a nice deep breath in and out. And again, looking for that nice symmetrical movement apart and at least 2 centimeters, and I'm happy with that. So I'm going to do the next test, which is tactile fremitus, which I'm using the ulnar surface of the ball of my hand to test the patient's chest wall. So I'm going to palpate again over all the lung fields anteriorly and posteriorly. So each time I touch the patient, I'm going to have them repeat 99. And I'm looking for areas of increased fremitus, decreased fremitus, or absent fremitus. So increased fremitus would be felt in an area of consolidation or lobar pneumonia. Decreased or absent fremitus is going to be in areas with pleural effusion, masses, pneumothoraces, or like a thickened chest wall with like a restrictive lung disease or interstitial lung disease. So yeah, I'm going to have you repeat the phrase 99 each time I touch my hands to your chest or your back, okay?
Okay. 99, 99, 99, 99, 99.
Perfect. So that all felt normal, so I'm going to get him to spin around again. And I'm going to do the same thing.
99, 99, 99, 99, 99, 99.
Perfect. All right, so those are my tests for palpation. So now I'm going to move on to percussion. So I'm going to get you to spin around forward again. So percussion is using the third finger on my left hand to place against the patient, and then using the third finger on my right hand to strike that hand and produce a note. So the notes that I'm looking for are resonance, dullness, or hyperresonance. So resonance would be heard on normal, healthy, air-filled lung tissue over most of the lungs. And dullness is going to be an abnormal sound. It's going to be a little flatter, and that's going to be heard over bone or fluid or a mass. You're also going to hear dullness over the liver and the lower ribs on the right side, and you're going to hear it in the precordial area on the left. So hyperresonance is the third sound, and that is like a louder, longer sound, and it represents air trapping in hyperinflative conditions like COPD. So I'm going to go ahead and get started with my percussion anteriorly. So I'm going to move in a ladder pattern from the apices all the way down to the lung bases. I'm being careful to go in the intercostal spaces and not over the bone. All right, so that was my anterior percussion, and I heard nice resonant sounds all over. So I'm going to get the patient to spin around again, and we're going to do this posteriorly. So again, I'm going to start in the apices and work down to the bases in a ladder sort of pattern. So posteriorly, you want to try and find those inner spaces and go between the scapula and not over the spine. All right, so I'm satisfied with that. I had nice resonant sounds throughout. So now I'm going to do the next test, which is diaphragmatic excursion. So that is measuring the difference between a fully recoiled lung and a fully expanded lung. So we're looking for the level of the diaphragm. So that's represented by a change from resonance to dullness on percussion. So what I'm going to do is have the patient take a nice deep breath in, out, and then hold it. And I'm going to percuss down for that, the level of the diaphragm. I'm going to mark that. And then I'm going to have the patient take a nice deep breath in, hold it, and I'm going to percuss down for the new level of the diaphragm and mark that. And then I'm going to measure the difference between the two, and it should be at least 3 to 5 centimeters, which would represent adequate expansion. If it was less than that, we might suspect we have like a restrictive lung disease or like a hyperinflative condition that's really moving that or limiting that diaphragm from moving. So to do this, I need my ruler and my pen. All right, so I'm going to have my patient take a nice deep breath in, blow it out, and hold it. Perfect, okay, so I'm going to mark that first level. All right, I'm going to give him a minute to recover. All right, and now I'm going to have you take a nice deep breath in and hold it. Perfect, okay, you can blow it out. So now I'm going to measure the distance between those two markings. And it is about 5 centimeters, which is perfect. That's exactly what we want. So that is a good diaphragmatic excursion test. So now I'm going to have my patient spin around anteriorly, and we're going to do some breath sounds, auscultation. Okay, so now I need my stethoscope for this. So I'm going to auscultate for normal and abnormal breath sounds over the anterior and posterior chest. Again, using ladder pattern, just like percussion, starting up in the apices, working down to the lung bases. So I'm looking for different types of breath sounds. So I'm looking for tracheal breath sounds over the trachea. I'm looking for bronchial breath sounds, which would be heard over the manubrium. And then I'm listening for bronchovesicular sounds, which would be heard in the first and second intercostal spaces anteriorly and between the scapula posteriorly. And then I'm listening for vesicular breath sounds over the rest of the lungs. So tracheal breath sounds are quite loud and high-pitched. The inspiratory sounds are longer than the expiratory sounds. Bronchial sounds, heard over the large airways, are loud and high-pitched as well, and expiratory sounds are longer than inspiratory sounds and are separated by a short gap. The bronchovesicular sounds are inspiration and expiration are about equal length. They're intermediate pitch and intensity and duration, and there may be a short gap between inspiration and expiration as well. And then the vesicular breath sounds heard over the rest of the lungs, they're like a lot softer and lower pitch, and inspiration is longer than expiration with no gap in between. Again, as I said, we're also listening for abnormal sounds such as crackles, wheezes, or rhonchi. So crackles are soft, kind of discontinuous sounds that are heard often best during inspiration, and they represent like fluid in the small airways or atelectasis. Wheezes are a louder, shrill, more musical sort of sound, and they're continuous. They're often heard during expiration, and they represent narrowed airways. They can be heard in inspiration as well, though, with really severe distress. And then rhonchi is a continuous, deep, snoring, kind of gurgling sound that's usually heard over the larger airways, and it represents secretions or blockages in those larger airways. So I'm going to start my auscultation now. I'm going to have you, when I put my stethoscope to your chest, I'm going to have you take a big deep breath in and out with your mouth open, please. Perfect. So that was great. I didn't hear anything abnormal anteriorly, so now I'm going to have the patient turn around and we're going to do the same thing posteriorly. All right, same thing when I touch my stethoscope to your back. Nice deep breath in and out with your mouth open. All right, so I'll get you to spin around forward again. Okay, so if I'd heard anything abnormal, as in I'd heard absent breath sounds or decreased breath sounds, or I heard a louder breath sound over the periphery of the lung, which would be abnormal, or if I detected anything abnormal on my percussion or anything suspicious for like a consolidation, then I could do a voice transmission test, which is one of the specialty tests as well. So the test that I've chosen to do for voice transmission for this OSCE is called whispered pectoriloquy. So what I'm going to do is, again, listen over the anterior and posterior chest in the same ladder pattern, but each time I touch my stethoscope to the patient's chest, I'm going to have them whisper 1, 2, 3. And so I'm looking for areas of increased sounds or absent sounds. Often you won't hear it very loudly. The most significant finding is that increased 1, 2, 3, that really clear, loud sound. So that's going to be heard over an area of consolidation or like lobar pneumonia. So again, I'm going to listen now. So each time I put my stethoscope to your chest, I'm going to have you whisper 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Perfect. And I'm going to get you to spin around, and we're going to do the same thing posteriorly. Perfect. All right. And that concludes my respiratory exam on this patient. Thank you.